بسم الله الرحمن الرحيم. هكلمكم النهارده على update in vestibular rehab. So many people think that the labyrinth is the only organ is the organ of balance, but this is not true. So the balance system consists of visual system, vestibular, and proprioceptive that all integrated together with the cerebellum and the brainstem to give the sense of balance. Dizziness is a non-specific symptom. So it's dizziness, go under lightheadedness, unsteadiness, disequilibrium of balance. So this is a foggy meaning for the sense of imbalance. So we need initial assessment. It could be vestibular, it could be brain pathology, it could be both, it could be neither. It could be cardiovascular, metabolic, or drug intake that affect the balance system. We cannot depend on the patient's symptoms if patient cannot understand his symptoms. There is a survey that done in 2007 in Mayo Clinic in the ER. So they found that the patient changed his symptom description within 10 minutes from the initial assessment. That means that some patients don't understand what the meaning of their dizziness or their symptoms. So it's unnecessary and inaccurate information will lead to confusion and misdiagnosis. And take in mind that always doctors and patients don't talk the same language. There is a study done by Alexander Bisdorff in 2009, according to the overview of the international classification of vestibular disorders. So it could be acute vestibular syndromes, could be episodic or chronic. So they make these three classifications. Acute, like stroke, vestibular neuritis, or labyrinthitis. The episodic that came in attack, and in between the attack, the patient is supposed to be completely free, like PPPV, Meniere's disease, migraine, and vestibular paroxysmia. Chronic, this is the bilateral vestibular hypofunction, or the PPPD, which is the persistent postural perceptual dizziness, or cerebellar ataxia. For the classification of the acute and the chronic, and there is also subacute. So we call any disease acute within the first 2 weeks. 2 weeks until 3 months, this is a subacute, and the chronic is if there is more than 3 months. Richard Zhu in 2019 put a conceptual framework for understanding vestibular disorder. So there are interrelations between different causes of dizziness. The PPV, the vestibular migraine, the Meniere, or can be mixed in real life. They are not separated. There is a modifier that is aging, anxiety, and head trauma. And also there is the maladaptation and the chronicity effect that end up by the PPPD. So, and there is also the psychological impact, like the roller coaster theory. So I will show you here a video. So what you expect when you are on a coaster like this? So what you are feeling? So some of us can be scared, some of us will enjoy. So it's different impact. So I just want to highlight that everyone is different, even same wind, same gravity, same surrounding environment, but it's different psychological impact. So first, the history taking is a cold stone to know how to reach our diagnosis. So Raymond van den Berg and Herman Kinga in 2021 recommend to focus on the time course and the triggers with the accompanying symptoms, but not on the type of vertigo. Because as we see, the type of vertigo can misdiagnose and can confuse us and even the patient. So they describe a 4-step approach for improving history taking in patients with non-acute vestibular symptoms. This is their diagram. First step is to describe the attack. Second step is describe the chronic symptoms. Third one, the psychological and comorbidity. And fourth step, to create a comprehensive diagnosis. So the first step, it's so-stoned paradigm. What's so-stoned? The S is since when starts the attack. The O is the occurrence, how often, or the time course. The S for symptom quality of the vertigo, dizziness, or disequilibrium, whatever the main symptom. T is the triggers. It's triggered by head movement, by walking, by drinking something, or sleep disorder. So what's the trigger? Or a car driver. Otological symptoms. It's hearing loss, tinnitus, oral fullness, hyperacusis, and for neurological symptoms like migraine or loss of consciousness. And we have to take care of the deadly Ds for neurological symptoms. These are diplopia, dysphagia, dysphonia, dysmetria, and dysesthesia. And the headache, the 3S for headache, is sudden, severe, and sustained headache. This is the red flag. Then E for evolution, how did it evolve? And D for the duration, how long does the disease last? Step 2, to describe the chronic symptoms, it's abbreviated in DISCO HAT. D for darkness, that warns the symptoms. I, imbalance. S, supermarket effect and visual vertigo and the conflict of the visual appearance. C for cognitive complaint. O, oscillopsia, double vision. H, head movement or that worsens the symptoms. A, autonomic complaint, and T for tiredness. Then step 3 is the psychological impact. They advise to do screening for functional, psychological, psychiatric comorbidity, to diagnose the PPPD, the hospital anxiety and depression scale can be used, and the dizziness handicap inventory as well. This leading to discrepancy between objective finding and subjective symptoms, because the psychological effect is play a major role in this, like anxiety, depression, avoidance of behavior. So the patient may restrict his movement and limit his activity due to fear of or scare of dizziness. This is what they did. The appendix that they used. Step 4 is to create a comprehensive diagnosis. It's a co-occurrence of various vestibular disorder. Is 3 plus 1. 3, that's the first 3 that we described earlier, acute or episodic or functional, and plus 1 is the combination of 2 of these or the 3 of these. Critical period for vestibular rehabilitation. This is another article by Michael Lacour in 2020. He mentions that the unilateral loss of vestibular function induces a vestibular syndrome, which is including postural, perceptive, and oculomotor, plus the neurodegenerative syndrome, like nausea and vomiting, and this is due to close functional relationship between vestibular nuclei and the neurodegenerative nuclei in the brainstem. And there is some symptoms related to the static deficit and or for the dynamic deficit. For the static, we find as oculomotor, from the oculomotor side, it's spontaneous vestibular nystagmus, view deviation, ocular cyclotorsion, from the postural, head or body tilt and muscle tone. Perceptive, this is a vertigo, subjective visual vertigo. If there is acute dynamic deficit, so we'll find BOR asymmetry, vestibular ocular reflex asymmetry, loss of head stabilization, and spatial disorientation. The static deficit recover over weeks or months in a process referred to the vestibular compensation, which is the plasticity. With the dynamic deficit poorly recover, new brain strategies can be used like restoration, remodeling, sensory and behavioral substitution. There is no really critical period. However, early rehabilitation accelerates spontaneous recovery and reduces the time constant of the vestibular compensation. The teen areas is better. Vestibular rehabilitation is an exercise-based group of approach that began with the aim to maximize the central nervous system compensation for vestibular pathology. The brain can fix what the brain can see, so the dynamic movement is the best. The brain needs a daily and constant rehabilitation. In acute, we need at least 12 minutes per day. For chronic, at least 20 minutes per day. Vestibular, there is a clinical practice guidelines. The new one was mentioned in 2020 that mentioned that vestibular physical therapy provides clear and substantial benefit to individuals with unilateral vestibular hypofunction and bilateral vestibular hypofunction. There is support for a variety of balanced training modalities, including the low technology, high-tech, virtual reality, optokinetic stimulation, platform perturbations, and Vibrotactile belt. Early intervention of vestibular physical therapy may optimize the rehabilitation outcomes. Dosage recommendation for balance and gaze stability exercise, as I mentioned earlier, it's about 12 minutes in acute and 20 minutes in chronic. But there is still a big debate in this area. Expand recommendation on factors that impact the outcome, as mild cognitive impairment and medication. If there is any medical history or any medication as vestibular suppressors they are taken. Also the mild cognitive impairment like MOCA screening test. Encourage walking for 30 minutes daily. Progression in exercise. We have to progress in the exercise. Don't make the difficult task first. No, make it from easy to difficult task. Even we can change the foot position, the surface, is it firm, and then make it foam. The visual, eye open first to be satisfied and to be self-confident, and then go to the eye closed. Environmental, we can make different visual background, added head movement, cognitive dual task, and dynamic tasks. Education must be in safe return to driving, daily activity, and return to work. So this needs more counseling to the patient. Strongly advise for supervision of the visual physical therapy via telehealth or self-teaching methods. We can learn the patient some methods of how to subjective scale his outcome. Stopping or discontinuation may be done according to the progress and reaching a plateau. Patients should participate in this decision when to stop. And this is here in this link, we can find the clinical practice guidelines, the ANTP clinical practice guidelines. Courtney Hall highlights the factors that can modify the rehabilitation, which are age and gender, different male from female, according to the age. Comorbidity, presence of anxiety, depression may negatively impact the rehabilitation outcome. Use of long-term of vestibular suppressant can affect also the outcome. Short-term use of low-dose antihistaminics may help to control symptoms without negatively impact the rehabilitation outcome. And of course, a good counseling should be done. So new advances in vestibular rehabilitation. This was presented by Susan Whitney. So first, the remodeling. In Mayo Clinic, researchers are working on using the artificial intelligence to help make decisions related to the exercise prescription. The use of machine learning to assist decision-making of vestibular rehabilitation scheme has important prospective reference significance in promoting clinical medical informatization and improving medical quality. Michael Straub et al. 2021 showed the Simont Plus maneuver. It's a new maneuver to improve the PPPV. It's different from the original or the classical Simont maneuver, with overextension of the head during step 2 brings the clot of otoconia beyond the vertex of the canal, which increases the effectivity. I will show you how it's done. So he takes the head down, take overextension. The normal, this is just until the bed, here overextension, and then to the other side, and then wait for 60 seconds. So this is the Simont Plus maneuver. So what's the PPPPD? It's a newly defined diagnostic syndrome that unifies key features of chronic subjective dizziness and unsteadiness. Patients with PPPD showed reduced connectivity among the area involved in multisensory vestibular processing. It's classified as functional disorder, not structural or psychiatric. It's characterized by persistent chronic vestibular syndrome lasting more than 3 months that is typically preceded by acute vestibular disorder. Symptoms of PPPD are dizziness, unsteadiness, or non-spinning vertigo. It's exacerbated by upright postural walking, active or passive movement, and exposure to moving or complex visual stimuli. This is a questionnaire for PPPD by Yagi 2019. It's 12 questions. The questionnaires are developed and validated for diagnosing and assessing the PPPD severity. The visual stimulation items were the best discriminators between those with PPPD and the control subject. The visual stimulation was the most characteristic exacerbating factor. A new technique used nowadays for vestibular rehabilitation is a virtual reality technique. So to be effective, it must be there is a sense of presence, elicit emotion, and generalized to the real life situation. So Weir and Sitars 2002 showed that virtual reality can induce adaptation in VOR and reduce dizziness. Combined virtual reality with a force platform can help. The Wii Balance Board, it's an interesting, fun game, even with vestibular neuritis. It can be helpful as kind of virtual reality to help for the vestibular compensation. Research was done on Parkinsonian patients by Stefano et al. 2017. The outcomes measure include the 4 risk tests, stability index, work balance scale, and TNT scale. There was functional improvement within fewer visits, detected with the 9-10 WeFit, improving the efficacy of intervention. Another study by Viziano et al. In 2018 reported that gaming home exercise are viable and effective measures to improve the long-term vestibular rehabilitation outcome. He found significant improvement of the VOR scale. The Vibrotactile biofeedback belt, it's a new and promising tool. This is a belt that applies to the trunk and it can restore the balance ability. The cell phone-based balance trainer. It's a good tool either for the home-based balance training evaluation. It reduces the body sway by giving some alert to the patient to change his, if he is swaying, just to change his body stability, same like the belt. It's of reasonable cost, size, weight, functionality, flexibility, and accessibility, because it's of course easy to use. Then I would highlight that the major key for any successful treatment is CAP. CAP is compliance, adherence, and persistence. Successful treatment of vestibular disorder includes the A3Ps, explanation and consultation. The 3 Ps are physiotherapy, pharmacology, and psychology. And the S is surgery if needed, and it's really here. And thank you.
Thank you very much, دكتورة غادة. الله يعطيك العافية يا رب. Very interesting lecture. الفيرتيجو أكيد موضوع شائك وأنا عن نفسي ضايع فيه، ما يعني أتوقع إن معظم الناس بيكونوا ضايعين فيه، ومش صعب إن نشخص الحالات كلها.
هو كل حتى الفيستيبولار بيرسون يعني أو physician all over the world بيقولوا نفس الكلام، إن أكتر حاجة الدكتور بيقلق منها أول ما يخش عليه البيشنت بيقول له I am busy.
يعني لما يفوت مريض عمره يعني 80 سنة وديزنس وكومبلين بكتب طول النهار.
بس هي دي general complaints that all are confusing, how to diagnose and how to help our patient to reach a right diagnosis.
Actually, in most of the cases, the dizziness that the patient is complaining is non-ENT. مرات كثير بيكون يعني المريض عنده multiple problems including يعني hypotension, neurological problems, motor problems, وبيجي متوقع انه الحل يكون في حبة بيتا سيرك او في منوفر. طيب نفتح الباب للأسئلة. حدا عنده اي سؤال، اي استفسار؟
طيب انا كنت عايزه اسال الدكتوره غاده، هو الحالات اللي هي زي المنيير والفلكتويتنج اللي بيجي لها ريكارنت فيستيبولار سيمبتومز دي بيبقى ليها بروتوكول مخصوص ولا هو البروتوكول العادي، ولا يعني لقيتي حاجه جديده في الليتريتشر عن الموضوع ده؟
والله يا لبنى، هو انا بحضر دلوقتي في فيستيبولار الانترناشونال دبلومه، فهي فيها حاجه عن المنيير بس انا لسه ما سمعتش الفيديو ده، فلو كده هسمعه، لو في حاجه اقول لك. لان هي في دي فيستيبولار دبلومه انا مجمعه منها الحاجات دي كلها، يعني انا بسمعها بس للاسف لسه ما وصلتش لجزء المنيير. انا كنت يعني كنت انترستد اكتر ان انا اسمع الفيديوز بتاعت الفيستيبولار، فلو كده هشوفها، ولو كده ممكن حتى اشير معاكي، مفيش مشكله خالص.
اوكي.
صباح الخير. جود مورنينج.
جود مورنينج.
انا كل ما احضر محاضره للديزي اكتئب، بسبب انه عندنا للاسف المرضى في السعوديه كلها، مو بس يعني في الفقيه، يعني ما بياخذوا حقهم في الديزي بسبب فيرست اوف اول البيزي كلينيك. يعني زي ما انتم شايفين بعض ابسط الكويستشنيرز او الاسسمنت تحتاج يعني اقل شيء يمكن 20-25 minutes. هذه واحد. ما في الكولابوريشنز بين الاي ان تي والاذر ديبارتمنتس. الشيء الثالث ما عندنا حتى ويل equipped vestibular lab، واللي انا تكلمت عليه من اول ما جيت مع يمكن دكتور مازن، قلنا نتمنى يكون عندنا space for more vestibular instruments and rehab. فعندنا عوامل كثيرة تخلي المريض هنا للأسف ما بياخذ حقه في التشخيص ولا في العلاج. الديزي فعلا very very complicated system. For example, the University of Toronto الديزي كلينيك المريض ياخذ 1 hour، ساعة كاملة. اللي بيكونوا حاضرين في العيادة otologist, neuro-otologist, neurologist, psychiatrist and audiologist, physiotherapist. Very complicated يعني process عشان تشوف one dizzy patient. ولكن هنا للأسف يعني ما بياخذ حقه المريض at all. فهذا ما يكومنت على الديزي. إن شاء الله يعني بدام فاهمين إحنا المشكلة في يوم حتتغير. إحنا بس لو كان عندنا سبيس كان يمكن يتغير شوية.
كمان اللي عندنا ما عندهمش فكرة أساسا عن الفيزيوثيرابي بتاع البالانس.
مظبوط.
يعني أنا سألت
كلمتهم كم مرة ما عندهم. مظبوط.
بالظبط كده. لا ما فيش حد منهم تريند إنه يديل with dizzy patient.
يبغى لها specialized training وغير يبغى لها special equipment، مو بس فيزيوثيرابي وخلاص سرير وسوي ثيرابي، يبغى لها equipment كثيرة.